Good morning, everyone. Nick Barris here with you on a Thursday. Thanks so much for joining us on the Big Show Morning Line. Good show on tap for you this morning. I think many of you will relate to this because you're either dealing with it or you certainly know someone who does, and it's diabetes. This is actually Diabetes Awareness Month. There's a lot of things dedicated this month to various illnesses and the like, but this is a big one that affects so many Americans. I want to get into that, about the details of what it is. Most of you have an idea of it, but you really understand why it causes damage to your body and what kind of treatments are out there and what you need to know. Just raising awareness along those lines. And as always, the number you see on the screen there, 615-737-7587. If you would like to join in the conversation, always welcome. But I'm looking forward to this. I love these health-related shows because I learned so much. I'm not diabetic. I have many friends who are. But let's answer some questions. We have two wonderful physicians joining us this morning from over at Meharry Medical Center, which is great. With us this morning is Tiwa Awosanya. She's an endocrinologist, internal medicine physician. Nice to have you, Tiwa.
Thank you for having me.
Thank you for coming on. Dr. Lawrence Burns also is a podiatrist at Meharry. Why do we have a podiatrist on this show? I understand the endocrinologist. Why do we have a podiatrist on the show?
Because if your patient has feet, you need a podiatrist.
Well, right. And you mean if your patient who is diabetic?
Period.
Well, yeah. Okay. So, but a podiatrist
we have a
involved?
sports medicine clinic as well.
Sure.
As we age, in terms of gerontology or geriatrics, there's a lack of balance. So you need people to take care of your feet.
Oh, no, I didn't mean
Absolutely.
that. Why do we need doctors for feet? But I was wondering, how does a podiatrist relate to those who are diabetic?
Oh, without a doubt. You're at a higher risk if you have diabetes.
Okay.
And so because we age and we don't see as well, our hands don't function as well, we're going to try to cut our own nails, and next thing you know, we're missing a toe.
Oh, no. What do you, oh, really? So, but there's circulation issues also, right?
Peripheral arterial disease, diabetic neuropathy, all that contributes, aging contributes, yes.
So you have amputated toes?
Yes, I have.
Okay, and that's an extreme, but that comes when eventually the blood circulation, because of diabetes, ceases to go into the extremities. If you don't,
And in addition, because the blood sugar is not controlled, what we call glycohemoglobin or A1C is not controlled, and that's why we work very closely with the endocrinologist to help maintain the patient's diabetes overall.
In extreme cases, if you don't amputate when it gets that bad, what happens?
The infection can spread through the body.
Gangrene?
More than gangrene. We talk about bacterial going and shutting down organs as a result of the infection.
So it's something you have to address.
Oh, absolutely, absolutely.
God, that's interesting. Okay, so before we get into more of the details, but I was curious about that. That's very interesting. Let's give a definition of what diabetes is for folks. I think most people obviously have heard it. They know people that have it, but do you really understand what it is, how it relates to insulin and the like? What's the easiest way you think to describe to people what diabetes does to your body?
For starters, diabetes is a lack of glucose processing. We call sugar glucose. That's the medical term or the physiological term. And so when a patient has diabetes, they are unable to process their blood sugar because of a lack of insulin or inadequate or insulin resistance, which just means that your body's producing insulin, but you're unable to use, it's not enough to take the glucose into the cells. And that's typically when we talk about patients that have type 1, they have some insulin production or they have none. And then we have patients that are type 2 who have insulin production, but they need a lot more to process simple blood sugar levels.
Okay. Good definition. And so the idea is, you have sugars in your blood system, and insulin needs to process it, get it into the cells, and move it. If it doesn't, those sugar molecules stay in the blood.
Yes.
And they're jagged. I mean, they're rough, and they move through your body and do damage.
Yes, they get deposited in organs like the kidneys, like the nerves that he's talking about that affect circulation. And so if it affects your nerves, you have something called neuropathy. It could be neuropathy around the stomach, which would lead to gastroparesis. It could be in the limbs, the lower limbs, and you have neuropathy, you can't feel your toes. So if you're hurt, under your feet. You don't know. You're just walking around.
Is that because blood flow is cut off to it?
No, there
or-
is blood flow. It's just a nerve issue.
So it affects the nerve, so you lose the feeling. And as he
And it
says,
progresses.
you know, if you don't have feeling and you can't see well and you're clipping your toenails, you end up cutting your toe and it gets
Correct.
infected or something like that.
And that infection then goes into the system. But then the glucose deposits everywhere, like your kidneys, your blood vessels, because as we know, diabetes quadruples your risk for a heart attack. And so it affects the blood vessels in the heart, the blood vessels in the brain, the lower extremities. And that's where he comes in.
Wow. So the sugar molecule, if not processed and left alone in the blood, can do a lot of damage.
Yes.
All right. You said about the type 1 and type 2 diabetes. I sometimes get them confused, but which is the one where, you know, you sometimes hear about folks who are diagnosed with it and they're very overweight, they get in shape and they start eating better and it goes away. Is that type 1 or 2?
So that's type 2.
Okay, so you want type 2. If you have a choice, you want type 2. You don't want type 1.
You don't have to be overweight though.
Oh, you don't have to be overweight. It could be anything. Okay,
You
so
could be.
type 1 or type 2. Type 2 is one that maybe through lifestyle changes you can perhaps
Exactly.
correct.
Yes.
Type 1 is the one maybe it's more genetic, or is it something that comes along that way?
I think both of them can be genetic. If you have a family history of diabetes, you could still have type 2. So we have risk factors and we classify them as modifiable and non-modifiable.
Okay.
And so the non-modifiable, whether you're type 1 or type 2, would be your genetics.
Genetics can't.
You can't fix that. Now we have modifiable, which could be your weight, your BMI. But again, it doesn't, what's that term? It doesn't discriminate.
Okay.
So regardless of your BMI, you could still have type 2 diabetes.
Oh, you could. So what's the difference between type 1 and type 2 then?
Yeah, so
Is
type
it-
1 patients have little to no insulin production.
Little to no. Okay, yeah, you said this earlier. And type 2 means they have.
And they have some insulin production, but they need more to kind of break down simple sugars.
Okay, I see. And so either one of those could potentially have a genetic component to
Yes.
it or something. But type 2 is the one maybe that's a little more manageable potentially.
Yes.
than
So
that?
you could, if you're obese, you could lose some weight and get back into remission.
Okay.
Or use 1 to 2 medications as opposed to all the medications we need for managing diabetes.
Do we know like how many Americans suffer from diabetes? I mean, is it 1 in 10? Is it, I mean, I don't know, and I don't want to. But you may not know
You're
those
very
numbers
close
off the top.
to about 1 in 10, yeah.
Something along those
10% or
lines.
so. Actually, it's going up to what, about 13% of the population now has diabetes?
Right. So I
Yeah.
think 38 million Americans have diabetes.
Okay.
If we bring it down to Tennessee, about 700,000 have diabetes.
Yeah.
About 250 of them don't even know they have diabetes. 250,000.
I know. Why would you not know? Okay. Aren't there symptoms that go with it? How do you?
Yes, so there's symptoms, but you can go for 5 years without having symptoms.
Oh, and meanwhile, there's damage being done to your body?
Yes, and so the 250,000 we talk about are those that have seen providers but didn't get their results or never went back for the results to have that conversation, or those results were overlooked. And so they're just walking around with diabetes.
Easiest way to diagnose it is what? Take a blood test
Yes.
and look for glucose levels?
Yes, you would take a blood test, or we do an A1C. But I think the first step is just having the habit of seeing a doctor or a nurse once a year. And then all those things can be caught.
So when I
Early
go,
on.
like I go and I do a cholesterol scan, triglyceride scan. They draw my blood twice a year or whatever, something like that. Do they? I guess is that a standard thing that they'll check for glucose levels?
Absolutely.
Okay, so that's where they would tell me, "Oh, Nick, by the way, we're looking. Your cholesterol sucks, but so does your blood sugar."
Yeah, but if Nick never goes back, Nick is not gonna know.
Well, if I went, I want to know the dang results of my test. Who
Yeah,
doesn't
thing.
go find out the results of their test?
People are nervous. Just getting into the hospital is a big step.
I know.
And
Isn't
then-
it interesting how that works? That you're nervous about finding out something you could treat, and you'd rather just live with it, that it could eventually kill you.
Yeah, and
It doesn't
because
really make
a lot of
sense. It's
times they're
irrational.
asymptomatic.
Right, it's asymptomatic, but eventually it will rear its ugly head. What type of symptoms then? If you have it for 5 years walking around, what kind of symptoms will you start to see?
I think that you're going to be very thirsty and maybe hungry often.
I had a cat that was diabetic.
Okay.
And it drank all the time. Okay, but no, thirsty, right?
Right.
Yeah.
And
I'll defer to her because she treats that.
Oh, okay.
the thirst.
Yeah, so they have excessive thirst, and then they pee a lot.
Okay.
And then
Is that because the kidneys are suffering? Is that
yeah,
that
so
have
the
something to do with the
kidneys have a threshold for sugar management, like how much they can filter.
Okay.
Beyond a certain threshold, they just dump it in the tubules, and so you pee it out. And so you're peeing out, it's termed polyuria, you just keep peeing. And then because you're peeing a lot, you're thirsty because you have all that sugar in your bloodstream. And then the third thing is weight loss without any effort put into it. You're just losing weight regardless of how much you're eating.
No matter how much you eat, you'll be losing weight. And does it do damage to the kidneys?
Yes.
Could you have kidney failure if it's not addressed?
For sure, you could end up on the dialysis chair with diabetes if it's not addressed.
Long-term complications.
Okay, now the other ones then, as we talked about at the beginning here, is that you could have issues with the feet. Is that one of the first places you would look once it's diagnosed to see how the feet are doing? But I guess you would notice if you're feeling numbness down there, wouldn't you?
Well, we test for numbness.
Okay.
On every visit for every patient.
Poke them with a needle or something?
We have different devices.
You pinch them?
Yeah. We have a vibration little gadget that we put up against the toe, and they close their eyes and they tell us when it stops or when they feel it or which toe it is.
And so
we
you can see
sort of
degree
determine
of how much they feel or something,
Absolutely,
right?
absolutely.
All right.
And now there's a way to test for autonomic neuropathy without doing invasive studies. And so that's a little test that we have over at Skyline Meharry that I utilize. And then when we find an autonomic neuropathy, then we refer back to internal medicine, family practice, or endocrinologist, because that's something that has to be managed. Because as she said, gastroparesis or just paralysis of your stomach where you don't process your foods properly, that's a part of autonomic neuropathy. And it affects your heart as well. I'll defer all that to her.
Yeah, but that's interesting.
But the interesting thing for feet is that African Americans and people of color have approximately a 4-time increase of amputation than anyone else, secondary to smoking, peripheral arterial disease, and other things like plaque from the cholesterol that you mentioned earlier. All these things jam up the blood flow, and as a result, if we can't get oxygen to the tissues, the tissues die.
And why is it a higher level, you think, among African Americans?
I think that there's some disparities, some healthcare disparities.
Okay, I didn't know if it was a genetic component
well.
or something, or if it's healthcare disparities.
It's a number of things.
Okay.
Yeah, our environment contributes to that as well. Our genetics, as she mentioned earlier, something we refer to as epigenetics. And I won't go deep into that, but again, deferring to her for those type of things.
Super interesting. All right, we'll take a break. We're going to take some phone calls. If you're dealing with diabetes or you know someone, give us a call, 737-7587. If you're on hold, stay there. We'll get to you. More of our conversation about this when we return. Back on Morning Line, we are talking diabetes this morning with two physicians from over at Meharry. It is Diabetes Awareness Month. Dr. Tiwa Awosanya is with us, along with Dr. Lawrence Burns, endocrinologist, foot doctor. And we kind of explained the roles they play. We have a caller that waited through the break. Let's take a call from George. George, good morning. Hi, George.
Good morning.
Morning.
How y'all doing? A good conversation going.
Thank you.
I just got... I'm going to hang up and y'all explain it. Sometimes you go to the doctor and he check you out. He said, oh, well, you're in good shape, but you're on the borderline. I'm going to increase your medicine. Y'all might be already talked about this, but sometimes it's all you get from the doctor. You know, I want you to tell me, what is the borderline? I'm going to hang up and listen for y'all.
Is that
Thank
enough?
you.
Okay.
Can he stay
Yeah,
on?
are you still there, sir? Hold on. Did you hang up already? I'm afraid he did.
Okay.
We can have him call back. But yeah, what does it mean, borderline? I figure you might have needed more information.
So borderline is most likely the prediabetes.
Okay, he's listening
The
at home. He's not
prediabetes
phone.
range,
Okay.
where you're not quite diabetic, but you have increased blood sugar level. And it's typically picked up when you go in and they do a random check, and your glucose would be a certain range, or they do an A1C and find out that it's in the pre-diabetic range. And so the plan for patients that have prediabetes would be to have them meet with a dietitian.
Would that be type 2 then, if it's
No,
or
it's
could it be
just,
type 1 too?
Oh yeah, prediabetes could be type 1 or type 2.
Okay.
But it's mostly type 2 because patients that have type 1, they have this phase called the honeymoon phase, and then they become full-blown diabetic. But you can be pre-diabetic for years if you're headed towards type 2.
Okay.
And so the plan then is to get on a medication and change your lifestyle and, kind of put an end to the dietary indiscretions and trying to change, kind of fix your lifestyle, basically, is all I'm trying to say.
Yeah, okay, so it doesn't mean if you take the proper steps and talk to your doctor, there's a chance you will not become full diabetic.
Yes, you can actually go back into remission with a lifestyle change if you're pre-diabetic.
Okay. The treatment for diabetes, if you have it, among other things with him, if you have to deal with foot or circulation issues, is insulin, right?
Did you say pre-diabetes?
No, just for if you're diabetic.
Yeah,
once you're
so-
full blown, is it you have to take insulin shots?
I mean, it depends on what type of diabetic patient you are. If you're type 1, you're stuck on insulin the rest of your life.
Okay.
If you're type 2, we have options, and then we have insulin for you as well.
If you're diabetic, are you supposed to really closely monitor your sugar intake or food intake in general?
In general, like I said, it's a lifestyle change. And so your carbohydrate intake, most of all, because we encourage more protein, more healthy fats, more vegetables, less of the carbohydrates, because that converts to
the
sugar.
bread converts to sugar. Bread, potatoes, things like that.
Yes,
convert to
everything
sugar.
we love.
I know. Now that doesn't mean you can't have a French fry once in a while. But
You can have one French fry in your mouth.
Is that
one.
what you tell them?
Yes,
Can't you just take a bunch of French fries and get an extra shot of insulin?
you can.
For real?
Actually. Yes, you can.
Okay, and I know we have a good friend that has an insulin pump. Those came into vogue how long? How many years ago you think have they been
It's
around?
been about 10 years.
Okay.
Yes,
Yeah.
and then we also have other meds that also kind of protect or minimize the risks of the complications of diabetes. But when we talk about the pump itself, the pump is out with an automated device called the CGM. And so with the pump and the CGM, which bypasses the finger sticks, we're able to get our blood sugar readings in real time.
Oh, see, because I remember, it used to be, it was second nature to him. I hate doing this, but he stopped, he'd his
Right.
finger, check it, and my blood sugar's up, or whatever, something like that. But now the pumps can do that.
Yes. So the pumps carry a certain amount of insulin, and you attach it to your body on the outside, and it administers the insulin into your bloodstream every hour. And so there are a lot of colleagues that are diabetic but don't want to bring out their shots. And so it gives them that privacy, that anonymity, I guess is the term, to manage their diabetes while they're sitting at the table like you and I. And then the CGMs, which is termed continuous glucose monitor, sends the blood sugar readings to the pump. And so if they're going too high, the pump gives them more insulin. If they're going too low, it
monitors it automatically. He doesn't have to
Yes.
check. It just
Doesn't have to do
adjusts as you go. So with a pump, is that enough to make it so that you don't have to monitor what you eat within reason?
You still do.
You still kind of have to. I mean, you
yes.
could really go off the deep end and it will
Yes.
get you.
Yes.
Does it happen, and maybe depending on the two types, more as people age? I mean, I know plenty of people that are type 1 that were diagnosed, when they were teenagers, but do we tend to see it as people get older, or is it run the gamut?
You can have diabetes regardless of the class at any age.
Okay.
Gone are the days where your type 1 diabetes is found in children. Now we're finding type 2 diabetes in children because of the diet, the level of obesity. Like, it doesn't discriminate. You can have type 1 and type 2 at any age.
I would just imagine, fair to say that wealthy countries have a much higher level of diabetes than, say, some of the countries that are third world. And what I mean by that is
Probably.
we've got all this rich stuff and we got a bunch of people pigging out. And in some of these other countries.
I actually think it's the opposite.
Well, now, because we have better medicine here?
It's the poverty countries that have more diabetes.
Because it's not being treated, or because I can't imagine it's because of their diet there.
It is related
What are they
to their
eating
diet.
there that's making, I mean, it's not, they don't have the rich foods that we have.
Yeah, right, exactly. But they don't have the basics in terms of vegetables and things of that nature.
So
The more
maybe they're
countries-
eating more of the carbohydrates.
Absolutely.
More carbohydrates. I do think that America has a high
Well, at least with the
prevalence of
children.
diabetes because of the sugars that we eat in our everyday meals and
And
going
now
to
we're
the
seeing a
movies.
lack of exercise among the youth, which is why she's saying we're seeing an increase in type 2, 12 years old and 13 years. We didn't normally get that until we became adults, adult onset diabetes. And now she's saying you can see it at 12 and 13, which is alarming because of a diet and because of lack of activity. We're on the video games instead of being out playing football
Exactly.
Absolutely.
or those
Sure.
type of things. Yeah.
Have you, for what you deal with you know, circulation and the foot issues and things,
Yeah.
have you seen young patients that have had to deal with that?
Absolutely.
How young?
Absolutely. 12, 13.
12
Yeah.
or 13 that
Yeah,
are
we're-
having issues with their feet?
No, they have diabetes.
Oh, okay, yeah,
Yeah,
but I
yeah.
mean, have you seen it where it gets to the point
No,
where
no,
not yet.
that's,
at that young
that's-
age, you
That's
haven't-
too early. Yeah, that's too early.
But you know that they could be on that path if they don't address it.
Oh, if they have diabetes, they will be on that path. It's just a matter of time. It's complications with your kidneys and with your heart, with your circulation, function. It all adds up long term. I've seen a lot of my elderly patients on dialysis, and nobody wants that. They're higher risk than anybody in the world for amputation and mortality. You get an amputation with a patient that's on end-stage renal, and probably within 2 years, they're dead.
Wow.
Yeah.
Okay, and an amputation, we talked about, it could be a toe, it could be a foot, it could be a whole leg.
Could be the whole leg, absolutely.
Okay, so that's why, but it usually will start at the extremities, so that's why I guess if you're diabetic, it's very important to have regular foot exams.
Exactly.
And insurance pays for that, so there's
It's
no
preventative,
reason.
right?
There's no reason for you not to come. We see patients typically somewhere between 9 and 12 weeks, depending on their conditions, and the insurance takes care of that. The insurance even takes care of a pair of shoes. And in terms of new technology, we have something called biologics. We're taking tissues from the placenta, tissues from the umbilical cord, and we're putting those on wounds, and we're getting enhanced healing. We have new devices for offloading, taking the pressure off the foot, that monitors the patient and tells us if they're wearing it or they're not wearing it, and how often they're wearing it. So there's so much new technology to prevent amputations. We're probably seeing over 150,000 amputations a year. And so our goal is to try to prevent that when possible.
And most of them are preventable. And then the issue is, again, as you said, where you get a wound down there, whether you clip yourself or you cut yourself or something,
Stepped on something.
because there is not as much blood flow, it doesn't heal normally as it would in someone who has normal blood flow.
And that's correct. But now, in addition, if their sugar's out of whack, if their glucose is out of whack, that makes everything more difficult. If they're under control, it's a lot easier. But when they're 12 and 13 and 15 with a glycohemoglobin or A1C, it makes our life much more difficult.
And that's where you just have to sit down with the parents and talk to them about.
Well, we're talking about adults. We're not talking about kids.
No, I thought you
Yeah.
said 15-year-olds or whatever. Or you're talking about
The A1C number.
A1C number.
Yes.
Oh, yeah.
I'm sorry.
Oh,
I'm sorry.
yeah.
Okay, but when you do have children that come in that are diabetic,
Well, when we counsel them on proper footwear, no bare feet around the house, don't try to self-care them, take care of themselves in terms of clipping their nails and things of that nature, we try to educate them, keep them out of trouble.
that's what we're doing this morning.
Yeah.
We'll take a break. Be back with more right after this. More. We are back on Morning Line talking diabetes. Are you watching? Are you dealing with it yourself? Do you have a diagnosis? We've got two doctors from Meharry on with us. They're terrific, trying to at least educate and answer some of your questions. And Laura has a call for us, so we'll take her next. Laura, good morning. Hi, Laura.
Hey, good morning, Nick, and good morning, doctors.
Good morning.
Hi.
Hi, so glad you guys are on today. I have a situation at hand. October the 21st, I think, United Healthcare sends once a year a nurse practitioner to my home to do tests, and I do go every 3 months to my own doctor for my blood work regarding my diabetes. I'm on Jarvian. But anyway, she came in October. She did the eye test. I got the results last week. I have, that upsets me a little bit, mild diabetes in my retinas.
Your retinas.
Yes, my retinas.
Does it affect your
So-
vision? Affect your vision?
Not right now.
Okay.
I mean, I still see fine, but I need to see an ophthalmologist, I think, and waiting for my doctor to find someone in my network. I'm just asking the question, what causes that?
Okay, good question. In the eyes, in the retina?
Yes. And so when you have high blood sugar, persistent high blood sugar levels, it just causes glycosylation of the vessels in the body and in the eyes. And what happens is the vessels kind of swell up and rupture, and so it causes micro bleeds in the eyes. And so when you have a lot of those micro bleeds, patients start to have blurry vision. And so we always recommend that for patients that are type 2, for example, when you get the diagnosis of diabetes, we ask you to go see your eye doctor so that the screening can start. Sometimes you're lucky enough as a type 2 diabetic to not have eye complications from the day of your diagnosis, because like I said earlier, they've probably had diabetes for 5 years not knowing, and because they were asymptomatic, all of those complications were ongoing silently. And so the mild retinopathy she's talking about is just blood vessels rupturing in the eyes, which can actually be from high blood pressure, but in her case, because the eye doctors can tell if it's from diabetes or hypertension.
So what will the treatment be for her? Did it sound to you like she's diabetic now, or pre-diabetic, or is that hard to know?
She's diabetic.
She's diabetic if they see
diabetic,
this.
yes.
So so she should be put on insulin, perhaps? I guess I know she's not your patient, but what would typically be a treatment for this?
So nowadays we don't start out with insulin because we have an array of meds. I call them beautiful meds.
You mean just for the eyes or for any?
For diabetes, because for the eyes, she's going to need surgery over time to fix those bleeds. Part of the reasons why there's increased risk for blindness is you have the bleeds, and then they go and they try to fix it, and then there's scarring in the eyes as well. And
That's
so,
permanent then?
Yes. And so you always have to get ahead of things when you have diabetes, because all the complications are silent until they're not. She's going to be okay, hopefully.
Okay.
She needs to tighten diabetes control, her blood sugar control, and her eye doctor, she needs those visits at least twice a year.
Okay, twice a year. Blood pressure control.
Blood pressure control.
Okay, and watching her diet and all of that as it goes. And you said you don't always necessarily put someone immediately on insulin in any case. What are these? What do you call them? Beautiful drugs?
They're meds there. So in the past, we used to focus on sugar control, solely on sugar control, blood glucose control. But over time, we found out that there were heart complications, kidney complications, feet complications.
Yeah.
And so now there are a lot of medications that are out there that minimize the risk of diabetes effect on the heart, minimize the risk of diabetes effect on the kidneys.
They thin the blood, thicken the blood.
They just attack the blood sugars once they're in the bloodstream, and they put a covering over the kidneys. They help with ultrafiltration when the kidneys are tired. And so those are the ways we kind of reduce the stress of diabetes on the organs, the important organs.
So I didn't know about those other drugs. I just thought it was usually insulin, but will there sometimes be a combination of those drugs with insulin
Yes,
as well?
especially if you're insulin resistant. Then we have to, insulin for me is always the last line.
Oh, really? And again, someone who's insulin resistant, then insulin's not going to help them.
They're going to need more and more insulin.
Much more,
yes. But the problem is insulin is a hormone that makes you gain weight. So the more I pile on the insulin, the more I increase your risk for obesity. So it's just...
Gosh. Yeah, right? It's a double-edged sword there.
Yes, it's a lot. And so diet is just as important as pharmacological intervention. Diet. Not going on a diet, but kind of changing your lifestyle and adopting healthier habits, healthier diets.
Okay. And again, the types of things when we talk about diet and remaining healthy are the same things with almost anything. If you want to protect your heart, if you want to stay healthy, is exercise, eating well, and then again, though, the emphasis is get the checkups and then follow up and get the results. So
Right.
it can be everything from the blood tests to going in if you're in this situation later, making sure someone gives you a full and thorough foot exam,
Exactly.
because that'll be the telltale sign on that. Does diabetes have any impact on people's cognitive abilities?
Yes, the way you have the microbleeds in the eyes, you could have it in the brain.
Oh, really?
Yes.
Oh.
So diabetes
Is that like an
quadruples
aneurysm
your
then?
risk for a heart attack and a stroke.
Oh, so a higher chance of heart attack or a stroke. It doesn't, but it doesn't, and so the bleeds, I guess, would that manifest itself in you having trouble thinking clearly?
Over time, we're finding that some of our diabetic patients have dementia. They have vascular affectation, which is causing the dementia.
So we think
yes.
that diabetes can have it.
Yes.
Seems like it can be.
Everything.
I was about to, you just took the word out of my mouth. I'm like, diabetes at some point or another, if it's not treated, can lead to any number of these other. There's no cancer connection, is there?
Are we going that route? Yes.
There is there too.
Yes.
Well, I may as well talk about it. All right, so we said everything.
Yes.
So there's a cancer connection for diabetes?
Yes, we're finding that when you have high blood sugar levels in your bloodstream, some cytokines are released that go and affect your blood vessels. And so those cytokines kind of, they also release antioxidants or oxidants that kind of put a stress on your heart, on your blood vessels, on your organs. And
Inflammatory as well.
Inflammatory,
And
yes,
so
that's
that
the word I was looking
inflammatory
for.
bit then could attribute to maybe some cancers that could appeal, or
So
tumors?
there's a link. There's a link
Okay, we think maybe a link
between diabetes
there.
and cancers.
All right, so cancer, heart disease, dementia,
Blindness,
blindness, amputations.
Yes.
All of these.
gastroparesis.
What is that?
That's just weakness of the muscles of the stomach to help with contraction.
Well, you're just terrifying everyone. That's just great.
No,
You're
that's
just,
not the
you're
goal.
I know, I'm just kidding.
The goal is to get ahead of it.
Exactly.
Prevention.
No,
Prevention
no,
is the key.
right.
prevention.
And that's the whole point, and that we want to emphasize is that all of these things that we're talking about is to make you take notice, but it's all preventable and treatable. None of this is like a death sentence if you do catch it and treat
Correct.
it. Let's go to Linda. Linda, good morning. Hi, Linda.
Good morning, fellas. I hope to get this out. I've had some surgery, so I want to know if there is a diabetes-free that affects maybe the elderly. I have a friend who never ate sweets, but now she is craving sweets all the time. She has to go to the bathroom constantly. Oh gosh, there was something else. But when she goes to the doctor says everything is okay for her age, and she's like 92 or 93. And I just wonder if there's really a diabetes-free now.
Huh. Diabetes 3, like there's 1, 2, and you think maybe she has some, but the doctors checked her blood and said that her blood sugar is okay. Is that your understanding?
They said it's okay.
Huh, but
I
you,
mean, I don't know.
well, it could be something else causing, but you say she all of a sudden has craving for sweets and is urinating and drinking a lot of water.
Oh yeah, and there's something else. I mean, she doesn't eat much protein, and just constantly eating sweets.
Well, that's interesting, and she's not diabetic. I mean, there could be some other medical condition going on, but the doctor says she's healthy for her age?
Yes, and most of us in the friend realm think that she may actually have some congestive heart failure going on too.
Yeah, at
So
that
I
age,
just wondered-
maybe. Yeah.
Yeah, I was just wondering if there have been studies on diabetes 3.
Have you ever heard of, I've not heard of that. Is there some hybrid of diabetes that would be a new category that you've heard of?
So yeah,
Yes.
that's
Really? Oh, well, how about
I'll
that?
let him go.
Look at him. Come on
not-
now. Come on.
No, I defer.
Well, what would be the third one?
I think what she's talking about is the dementia one, the Alzheimer's.
Maybe.
What do you think?
Possibly. I've been hearing about a type 3. I'm not quite sure how that works, but yeah.
I mean, a type 3, I guess it's still would involve insulin, and I
So
mean,
so the type 3, I think the type 3 that they're telling her about, if the patient is diabetic, would be the dementia component to it.
Okay. Okay. And what she described is her drinking a lot and urinating and eating lots. Well, eating a lot of sugar, that's not part of being diabetic. That doesn't give you you don't want to eat as much sugars, but when you're diabetic, do you have cravings for sugar?
Some people do,
Oh,
but
really?
she's not diabetic.
Right. She's not diabetic. They checked it.
So she's 92 and she's living her best life.
Yeah, if she's enjoying the sugars and she's happy as a clam, keep it up. At that age, I mean, at some point in the game, you just enjoy yourself as long as the doctor says, don't worry about that. I mean, all right, so before we get in our last segment, I'm really going to want to talk about just the most ways of prevention, but in terms of treatments, anything else on the horizon? I mean, it seemed like there was a huge leap forward when they came up with insulin pumps and
Yes.
these new drugs you're talking about. Is there anything else in the works that they think could improve the lives for diabetic patients?
Yes, I think the next thing on the horizon is the artificial pancreas, is what we call it,
Okay.
where it has some parts where you can place the insulin and the hormone glucagon, because that's what the endocrine function of the pancreas does. It kind of regulates insulin and glucagon. So when your blood sugar is low, it releases glucagon.
But isn't
to
that what a
help with
pump does?
hypoglycemia. The pump only has a compartment for insulin, but the future is putting glucagon in another compartment in the pump, such that when you're going low, you don't have to reach for sugar. It just releases glucagon into your bloodstream to help with the lows.
Okay, but I thought when you get low or high now, they can either, the pump adjusts
It
to how
adjusts.
much or how little insulin.
Yes.
But it doesn't do, okay, but that alone doesn't always.
It's not enough. Some patients
that's
still
interesting.
have hypoglycemia, and if you have it in the right setting, bad things can happen.
Interesting.
And so the pump is now going to contain that that compartment that has glucagon that helps with sugar formation or creation or genesis, to reduce your risks of going low and crashing out.
It's like an artificial pancreas.
It is an artificial pancreas.
Those aren't widely available
Not
yet.
yet.
That-
It's
but
still
that's
in the works.
but that's what I was
That's
wondering.
the
I think that's
future.
wonderful you shared that. That is fascinating. We'll take a break. Final segment right after this. Just found out we're both from Chicago. Where are you from?
Nigeria. Rapping.
Nigeria. They don't have Chicago-style pizza
No,
there,
we
do they?
don't.
See, we're talking about pizza, and we were talking about pizzas during the break because, among other things, I was saying, okay, folks who are diabetic have to watch what they eat, but that doesn't mean they have to cut out everything they love. And she was very profound in saying, if you do that, make sure it's worth it. What do you?
Better be worth it. Life is for the leaving. It better be worth it.
Okay, worth
But
it.
get right back on track.
Well, it's like
after
anything.
that.
People on a diet, they have a cheat day or something. Do you
Yes.
have cheat days as a diabetic?
Yes, I actually recommend it.
How does that work? The same way as someone on a diet, or would it be once a week? Once a, you know,
I would
how would you
say
guide someone?
one day in the week, you be good for 6 days, and the 7th day, just live your best life, have fun. But on the first day, back on the first day after you binge, you have to get right back on track.
But when you say binge, I mean, I would think it's a little different because your sugars could go wacko that one day.
Can.
So you don't want to go too. I mean, I know some people are on diets or whatever, or workout regimens. They go 6 days, but they're not diabetic. On the 7th, they just really overdo it. And they bounce back the
They
next
bounce
day.
back,
But if you're
yes.
diabetic, that could be problematic.
I would
So you
say
gotta
one
kinda-
meal. It's
one
usually
meal.
on a Sunday where everybody's out after service. It's
Yeah.
just one
Something nice like
lunch
that.
with a nice dessert.
And that's okay. Now, on the rest of the week, though, that doesn't mean you just can't eat stuff that you like. It's.
I mean, if you want to, you have to give yourself coverage for it, especially if you're on insulin. So if you're gonna have 2 cookies, then give yourself some units of insulin to cover that, because the goal is to make sure there's no hyperglycemia, which is elevated blood sugar readings.
Okay, but if you're just someone who all you like is sashimi and steak and chicken and, Brussels sprouts, you can eat as much of that as you want.
Knock yourself out.
that stuff's okay
Yes.
because there's no carbs.
Yes. Now I want you to eat carbs. Your brain needs sugar, quite all right. But I would say very minimal carbs and a lot of protein.
Okay.
It keeps you fuller longer.
Okay. Are there things people can do to improve their circulation besides the diet if they're diagnosed, and what kind of exercises they can do with their feet? Is there things
Walking.
like that? Okay.
Walking. That's our objective, is to keep people active, keep them mobile. And so having the proper fitting shoes. I saw a guy the other day in clinic with the family practice residents over at Skyline. He had a size 17 shoe and he looked like he was maybe a 12.
Oh.
And I'm like, your shoes are a little bit too, I like it like this. I want it too big. But that's not good.
Yeah. I guess he says it's comfortable. But you would want a shoe that fits.
That fits, to be measured and fit properly. Yes.
And a certain type of comfort. You know, there's all these shoes with the big soles these days and all of this. I mean, the pounding and stuff you want to avoid, or?
When we walk, there's 1 1/2 times our body weight exerted onto our foot. When we run, we're talking 3 to 5 times our body weight. And so having a proper fitting shoe is important to keep you mobile.
Okay. And so walking on a regular basis is important.
Walking is
And that
fantastic.
improves circulation. What about, after we're just sitting there, what about getting foot massages? I love foot massages.
Foot massages
They're so
are great, but it won't substitute for improving your circulation.
It won't? I thought that
No.
would get it. You're sitting there rubbing the toes and everything and get it going. No?
No, you have to walk. You have to walk.
Okay, you have to walk. Are you also going to, especially in the wintertime, if you have a circulation problem, will you notice cold sensitivity or numbness? I mean, if you don't have the numbness yet that comes with it, but there's circ problems, do you have cold sensitivities?
Yeah, it could be. I don't see that as much. I see it more with something called peripheral arterial disease. It's an underdiagnosed problem, and we won't find symptoms of intermittent claudication, and that's cramping. When you walk a block or two, you have to stop and rest until 60% of the blood vessel is occluded. And so that's a little bit down the line. So if we can prevent that, you come in for your visits, we palpate your pulses, and if they're abnormal, we do something called an arterial Doppler test that tells us how your vessels are functioning. So we know early on if you're at a higher risk or a lower risk.
As far as the preventative things, we were talking about just stuff that insurance covers, like some of these different procedures, the exams of the foot and such. I mean, are some of them in most insurances because they're preventative covered? Do you get a
Absolutely.
sense?
Foot care is a covered service for patients with diabetes. People at higher risk, like smokers, elderly. It's a covered service.
So it is a covered service. To do the exam, like?
Just to come in for regular visits.
Oh, okay. And blood tests and the like?
Yes, that's covered.
And again, when you do basic blood tests, sometimes if it's just part of a physical, that is something that'll be included. They're going to check your blood glucose. Is that what it is, blood glucose?
Yeah, so the expectation is when you're 45 and older, we have to check your A1C. That's the recommendation. If you have a history of high blood pressure, we have to screen for diabetes. So they're guidelines that we have to follow. If you're overweight or obese, we could screen for diabetes as well, because it's not every obese person that has diabetes. So you have to have a conversation with your patients. But yes, I think the first step is getting a provider, a doctor, having the yearly visits. And then anything that's wrong can be caught on time, and then that kind of helps with early intervention.
Definition of obese would be what percentage over your body?
So if your BMI is 30 and greater.
30 or greater. Okay, whatever that means in terms of you're going to know.
Well, you can simplify it. If a male's waist is over 42, then they have metabolic syndrome and they're prone for diabetes.
If the waist is over 42
inches, yes.
Inches.
Yes.
Okay.
I'm not sure on females.
I think it's 38 to 40.
Okay, so that'll be, in general, a rule of thumb that you look at something like that. And all right. And any other tips for folks on the side of prevention? We kind of touched on most of it. And is there any kind of supplement or anything like that? I don't know how you feel about supplements or vitamins that can help with this. Is maybe once you have diabetes, or to try to prevent it.
So I think
Vitamins that help.
Supplements are always great. Vitamin D helps.
What does it do? What does vitamin D do?
Vitamin D, there are several studies showing that vitamin D given to babies, newborns, reduces their risk for type 1 diabetes.
Okay. Yeah, that helps
Yeah,
for a lot
so-
of stuff. And that's in cod liver oil. I take a teaspoon of that every morning.
You're never going to be diabetic, I promise.
Probably, I take it for my eyes. All right. Well, I could, who knows. But okay, so vitamin D maybe, which
Right.
can help for a lot of things. Anything else, does it help to go get a pedicure?
B complex. For people with numbness and tingling, what we refer to as diabetic neuropathy, we found that some of the B vitamins work very well.
What about a vitamin B12 shot in the butt?
That's a little different.
That's when you have a dietary insufficiency.
Oh, okay. I didn't know if that would help. You know, that's really bright red. You ever seen that? The B12 injections?
And you can put it in your thigh. It doesn't have to be the butt.
I know. I like it in my hip. It doesn't hurt as much. And I had one a long time ago.
But
so I don't need
I
that.
think that self-education, educating our patients, whether they're diabetic or not, on the risks of diabetes helps.
Yeah.
And I think that's the number one thing. Another high study that was done recently showed that it helps reduce the risk of complications and improves their outcome by about 1%.
If what?
If they're self-motivated,
Yes, of course.
self-educated,
Sure,
yes, and
sure.
they kind of fix their diet.
Okay, and knowing all of that, and also being aware of your family history to a
Yes,
degree. If you
important.
see, so if you have a grandmother or your father had it, then it's something maybe you should get. There's not genetic markers for that you can test for.
Not
is
that I
there?
know of. It's not my line.
But if you have it in your family, but the fact that you don't have it in your family doesn't mean that you may not encounter it, depending
You
on
can
what your
eat your
lifestyle
way
is.
into it.
Absolutely,
Yeah.
you could. So you think if I just threw everything out the window and tried to get diabetic, I could?
You could. You would be very successful.
So anyone could.
Anyone, yes.
Who would want to do that? You guys are awesome.
Thank you.
For tolerating me. Thank you for tolerating me. This was her first time doing TV like this. I thought she was excellent.
Absolutely,
You're
she
excellent.
was.
Thank you.
It is a pleasure. You two, check with the
Good to
doctors.
see you again.
Yeah, it's good to see you. And just make sure you take note of this. Share what you've heard on the program this morning and go have the physicals and when you have the blood test. And the important thing, which still I don't get, if you go, they do the tests, follow up and find out what the heck it was.
Yes.
Hopefully your doctor, if there's an issue, will contact you after the fact if they see something like that. But, don't just go and then forget about it. I know some people are afraid to go or afraid to get the answers. But that's self-defeating, isn't it? If you have something that can be treated, you want to know about it. And the bottom line on this is diabetes can be treated and you can live a normal life.
Exactly.
Absolutely.
Thank you both for coming on. You guys
Thanks
are
for
great.
having us.
Thank you.
I'll be back with a programming note right after this. Stay with us.